Thank you, Mr. Chairman. Gentlemen, thank you both for being here. Ladies. First, I'd like to have a question for Secretary Wolf. I'd just like to follow up a little bit more on Representative Baker's questioning, and when you provide that information, if you could also provide us with the money that's gone into the student loan forgiveness. I believe that was a 10-year. Is that a 10-year payback? The commitment is a 10-year.
It's not. It won't be a 10-year commitment at any longer. If you give me one quick second, I believe we're knocking it down to 3 to 4 years in medically underserved that they work for 3 to 4 years in that medically underserved areas, if I remember correctly, and we'll confirm this. That we're going to put that into a 2-year commitment as well. One of the challenges that the state of Pennsylvania has had, especially for an area like yours, where we're competing against other states and other state programs, one of our biggest challenges is that until we're in that process of redesigning right now, we've not been able to match what other states are doing. And because we've not been able to match what other states are doing and what the federal government is doing, we're losing students. You have a wonderful institution up in your area with the Lake Erie Osteopathic School of Medicine. Do a tremendous job of providing and creating family docs, and we think if we can do a better job making sure we're retaining those kind of folks and doing a better job of keeping a relatively small percentage of the medical students here in the state of Pennsylvania to practice in the state of Pennsylvania, we're going to be in much better shape.
And the intent was to focus on the rural and the underserved
right.
areas, and I'd really like to be interested to know on, how successfully we are on keeping them in those areas once we've repaid their loans.
So one of the things that, and we'll be happy to get back to you with that specific information, the American Medical Association has said about 70% of the physicians, wherever they do their residency, is where they have where they tend to stay. So if you're looking at it, you think of it in that manner. If we're able to keep that some percentage around there, I think that would be a very positive step moving forward for us.
I'd be interested to see those numbers. Obviously, the program hasn't been in existence for a terribly long time at this point, and so, I realize that it'd be kind of difficult to narrow it down.
Sure.
But I'd really like to know if they're jumping out right away.
Sure, we'd be happy to.
And for Secretary Tannis, we've got a lot of money that goes into trying to treat people with addiction. And that's kind of a two-part question. We know that recidivism is always a concern, and I'd like to know if you could supply some numbers to the committee that kind of breaks it down to how much of an investment is it per person or per addiction, to be able to get to that success rate that we're really looking for.
Well, it really needs to. That's a great question. It really needs to be individualized, because when I was talking about clinical integrity, I was really talking about doing a good individualized drug and alcohol assessment. We have something called the Pennsylvania Client Placement Criteria that says where that individual needs to go. And I'm going to just to tout the kind of results, Pennsylvania Commission on Crime and Delinquency, which pretty much consistently does a beautiful job with everything they do, has a restrictive intermediate punishment treatment program. They're about to come out with a study, and for those, we got a number of former prosecutors in the room. The recidivism rates are 13.9% for those who get diverted into treatment. Now, these are drug addicted or alcohol addicted criminal justice offenders that are committing pretty serious crimes. They would be almost all coming back, but we're getting the recidivism rate down to 13.9% at 12 months, about 17% at 2 years after completing the entire program, at which point it pretty much flattens out. For drunk drivers, the recidivism rate is 2.9%. The folks that are committing multiple drunk drivings and other offenses are getting better almost entirely in drug and alcohol treatment. And the impact, if we were to treat, and we have a law in the books, unfortunately not well enforced, if we were to treat everybody that came in that had an alcohol problem or a drug and alcohol problem that had drunk drivers, this is the kind of impact we would have. In Department of Corrections today, 5,100 offenders are sitting in there who had a prior DUI. We had an intervention opportunity to do drug and alcohol treatment with those kind of recidivism rates. Those individuals, for the most part, could be out sober, working their jobs, supporting a family, but instead they're sitting in the Department of Corrections after having committed mostly violent offenses. So 5,100 had a DUI before they committed the offense that's got them locked up right now. The potential impact here for this investment, the potential return on the investment is enormous. And the research shows about a $7 return in reduced criminal justice costs for every dollar invested in treatment, and another $5 in reduced health care costs. So it's a tremendous return on the investment. This is the one disease we should really be going all out on taking care of if we want to make the job of the Appropriations Committee a little easier.
Well, and you touched on the fact that they need to complete the programs. So any information you could give the committee on, not a total breakdown, but especially for probably heroin and alcohol, opiates, what would be the length of those treatment periods that are suggested and the cost per individual to complete those treatments?
We'll send you some examples, like some scenarios of that. But I would say with someone with a serious opioid addiction, the sweet spot's probably, it depends on the individual, is probably going to come in around 6 months residential, followed by intensive outpatient with supportive housing and working with the wraparound services. And the cost, again, is going to, we'll get that to you, but the cost of not doing it is an individual who's going to cycle in and out of our our criminal justice system, hurting people all the while, committing several crimes a day. We could reduce our crime rates. If we get to the point where we fully fund this disease, we can reduce our crime rates by more than half, and it will take years. It'll take us a long time to build up to that point, but if we do it, we will have safer communities, and you'll be spending far less money because of the savings on shutting down prisons and jails and all the other costs from taking care of this. Untreated addiction is what drives crime in Pennsylvania and in the nation for the most part. That's just a fact. And the more we can wrap our arms around that and decide we're going to take care of that, then the more we're going to end up saving a lot of money and having a lot less suffering in our communities, both the families, the 1 out of 4 families with the disease, and those who are committing crimes, which is a minority of people with addiction, but they're still committing most of the crimes, a lot fewer crime victims.
Thank you. Thank you, Mr. Chair.